we start now?
Yeah, please.
Hello and a very good evening to all. I thank each and every one present here for sparing their precious time. I am Dr. Sumita Bansal, co-chair Dioh. I would like to welcome you all on the behalf of Dioh Group to our scientific webinar titled Diabetes, Periodontitis and Systemic Nexus, a spotlight on the clinical evidence. Today, there will be some very informative lectures by eminent speakers from the specialties of diabetology and periodontology, hoping for a great and successful event today. Now we start the program with the introduction of our moderator, Professor Dr. Sangeeta Dheer, so that she can further commence the program. Professor Dr. Sangeeta Dheer did her master's in periodontology from College of Dental Sciences, Davangere, Karnataka, and clinical externship program in implantology from the University of Birmingham. She has been credentialed by International Congress of Oral Implantology, and she has been into academics for the past 20 years. She maintains a private practice since 16 years in Faridabad. She is a consultant at Max Super Speciality Hospital, New Delhi. Her area of interest is oral implantology and periodontal medicine. She has been a principal investigator and co-investigator in various grant-aided and research projects. She has several index publications to her credit, and she has contributed book chapters in specialties of cardiology, diabetology, and dentistry. She is a reviewer to several specialty medical and dental journals. She has been a keynote and guest speaker at several dental and medical meetings on national and international forums. She has been the ex-core committee member of National Oral Health Program. She has served Indian Society of Periodontology in various capacities as president, executive member, national convener, prenatal periodontal healthcare committee, assistant editor, Journal of ISP. She has been the ex-editor-in-chief, Journal of International Clinical Dental Research Organization. So over to you, ma'am.
Thank you, Dr. Sumita, for the introduction. A warm welcome has already been extended. So on behalf of DIOH, I just extend a warm welcome once again to the chief guest for the evening, the Diabetes India Secretary, Dr. Bansi Sabu, sir, Dr. Manoj Chawla, sir, the chairpersons for the evening, and the esteemed speaker list which is lined up for the webinar. And once again, a big round of applause for the delegates who have logged in. And with that, I would initiate the invoking of the goddess Saraswati before we start the program. Can we have the lamp lighting, please? I assume Neerav wanted to first display the AV of DI India. Neerav, can we have the lamp lighting, please?
Neerav? That was very impressive, Dr. Dheer.
So we wanted the lamp lighting. Why? Where is the lamp lighting, Neerav? Neerav? Anyways, we will just memorize the goddess Saraswati in our minds and we take her blessings to take it forward. So may I now invite the Diabetes India Secretary, Dr. Bansi Sabu, sir, to just speak few words on the subject and the webinar, sir. Over to you.
Dear Sangeeta, first of all, thank you. Thank you for inviting me. Thank you for conducting this wonderful program. And I can tell you that it is the most active group of Diabetes India. Diabetes India Oral Health Special Interest Group, which has been created. And with the help of Sangeeta, I am sure that, many of the doctors across the country are getting the benefit of it. But she had really created a wonderful program. She's very, very active. And I must congratulate Sangeeta again and again for this wonderful program and whatever the activities which she's doing. But one thing which I just want to tell, that the idea of creating different interest group under Diabetes India, because diabetes is having issues related to all parts of the body, and which is oral health is less recognized, less talked about it, and less physicians are giving importance to the oral health. And that's the reason a timely reference of a people with diabetes is not done. Ideally, there are international organization, American Diabetic Organization Association is saying that twice in a year, a regular dental checkup and oral health checkup is required for persons with diabetes. That is what has been recommended. We also have initiated such recommendation should also come from Diabetes India. At this point of time, the online or webinar is the best way to, for the disseminating the knowledge, as people sitting in, like Sangeeta is in Delhi and I am in Ahmedabad, and many people are from different parts of the country. Manoj is at Mumbai, and many dental specialists also from different parts of the country. So, we can get the doctors from all across the country. Diabetes India, we have a fellowship program. So we will see that in future, can we create for a special interest group also some fellowship program under banner of Diabetes India. That is what our future plan is. This year, we have Diabetes India meeting in 2025 at Ahmedabad, along with Diabetes Asia Study Group. Last year, we have a very grand successful meeting. It was in Bhubaneswar, east part of the country. Now it is coming to the western part of India. So I welcome all the delegates to come physically in person for Diabetes India meeting from 13th Feb to 17th Feb at Ahmedabad. We will also have, during our annual meeting, all interest group meeting is also there. So we will have the interest group meeting of oral health also during our annual meeting of Diabetes India. With this webinar, after this webinar, we may come out with some small booklet or some newsletter, some important information, because there are doctors who will be attending it, but many more doctors may not attend it also. So a continuous education program can go, and even they can, read even in the clinic also. So with the electronic media, we can send the details of this or some of the important clinical information which we can disseminate with the news or in the form of some leaflets. We are also planning to have some education leaflet under this group by Diabetes India Oral Health Group, because that is very much required, which we can put in our reception. Diabetologists and physicians, they are more. But at the same time, the dental complete all dental group or all dental doctors, they also need a lot of education for diabetes. I have seen that they are the uncontrolled diabetic patients are also treated with a dental treatment, and then they develop infection, and they don't tell the patients that about how important to have a tight control of diabetes. So these are also very important. This is the reason this group is having doctors from both the specialty, physician as well as dentist. Definitely the specialty is diabetologist versus periodontologist. And we will have more interaction with this webinar, and I am sure many doctors of both the fraternity will get the benefit of it. Once again, thank you, Sangeeta, for conducting this, and thank you for invitation. Thank you very much.
Thank you, Dr. Bansi, for your motivational words as always. Thank you so much for your presence for the inauguration. Neera would like to play the Saraswati Vandana. Could we have Neera, please?
वक्रतुण्ड महाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
You are mute, Dr. Sangeeta.
Sorry. Okay. We would like to invite the chief guest for the evening, Dr. Viveka Kumar. Can we have his bio sketch, please? It's indeed a privilege and honor to invite somebody of his stature for this dental meeting. I've been knowing Dr. Viveka Kumar for a good number of years now. He is somebody who has attained his expertise over the years and yet very humble. He did his MBBS and MD from Banaras Hindu University, Uttar Pradesh, and DM Cardiology from LPS Institute Cardiology, Kanpur. He did his training in interventional cardiology and electrophysiology from London and Southampton University, London. He holds a fellowship from Society of Cardiovascular Angiography Interventions, European Society of Cardiology, and South Asian Interventional Society. His clinical expertise goes just innumerable, with about 50,000 interventions in cardiac devices. He's a structural heart disease specialist. He's a national and international proctor for various cardiac device companies. He holds a credit of editor for 7 books and authored more than 20 chapters in various textbooks and publications in national and international journals. His award list is long and is beyond this window of the bio sketch, yet we have tried to condense it. He has an IMA honors at the National Heart Failure Conclave 2022. He has his American Association of Cardiologists of Indian origin in the year 2021. He has got a DMA Distinguished Service Award in 2016. He has got IMA Dr. K. Sharan Cardiology Expertise Award. He has got Lifetime Achievement Award from Gastric Society of India. He has got WCC PC International Award of Excellence in Cardiology. He has got Vidya Ratan Award from Kanpur University 2010. And he also has got a Chikitsak Award in the year to follow. Sir holds as a post of Principal Director-in-Chief of Cath Labs, Max Super Speciality Hospital, New Delhi. Over to you, sir, for your kind words, please.
Yeah, so first of all, good evening to you all, and special thanks to Dr. Sangeeta. So it's basically, I could understand that it's a meeting of Diabetology India plus the, dental group, so Dioh, and then, so it's a very good initiative. I must compliment both of you because we consider that diabetes is mother of most of the diseases. So it's a common soil which can cause cardiovascular disease, and probably that may be the reason why Dr. Sangeeta wanted me to be here. We see that, if you look at the reality, we are closely associated. So half diabetologists we become because there are a lot of advances. And as Dr. Bansi said, that, the how do we treat diabetes, that matters a lot, and awareness not only among cardiologists and the other physician, but also the dental specialist also has to be there. And with Dr. Sangeeta, we have done, and we are still doing few projects where, the Association of Diabetes, the dental issues, the periodontitis, and then the cardiovascular disease, especially the coronary artery disease, we have done projects, and that's quite a few of them is going on. So we have established that there is a very close relation, and there is enough data to suggest that people who have got dental infections and all, they have high risk of acute coronary syndrome and coronary artery disease per se. So I think today's webinar would enrich all of us, and people will go wiser. And I think all the speakers, they are quite experienced in their field, and I wish them good luck, and all the audience who are joining this meeting. And a special thanks to Dr. Sangeeta for bringing me to a new chapter in diabetes and oral health collaboration. So that will be very fascinating evening. So over to Dr. Sangeeta.
Thank you, Dr. Viveka, sir, for accepting the invitation, and thank you so much for your motivational words. And we would love to have you towards the evening. I do understand your busy schedule. So anytime would you like to, rejoin, we are welcome to have you over, sir. Can we have Dr. Manoj Chawla to just have a few words from you, sir? Dr. Manoj Chawla. Dr. Manoj Chawla. He has unmuted. Maybe we can just rejoin him at a point. Okay. With this, we come to the end of the inaugural ceremony.
No, Manoj must be there only because
no, he is unmuted.
He and Purvi both are there.
So I'm just trying to connect Dr. Manoj Chawla. I think he's unmuted, sir. So I don't know.
Purvi is there also. Rutul is calling, I think, Manoj. Manoj is there.
Yeah. He's
Manoj,
there.
yes, please.
Dr. Manoj, please.
Sorry,
yeah.
No, I missed it. Sorry.
Dr. Manoj, can
we inviting you for a few words?
Yeah, few words.
Okay, that's kind of you. Thank you. No, I think it's amazing to see these initiatives being taken and the connect between the oral health and the dental community and the physician community. We must congratulate the entire team of Diabetes India Oral Health, spearheaded enthusiastically by Dr. Sangeeta, for these kind of collaborative initiatives to bring about awareness on the topic of diabetes and oral health, a need for both the faculties to collaborate and ensure that the physicians are constantly aware of the oral hygiene and oral health problems, and at the same time, the entire dental and periodontal community is constantly reminded of the impact that hyperglycemia and diabetes can have on oral health. So once again, let me take this opportunity to welcome all of you who are joining in today from all across for this academic initiative. Let me thank all the speakers from both the faculties who have spared their time and taken time out to speak today. And once again, congratulate the entire core community of Diabetes India Oral Health for such initiatives. It's an absolute pleasure being associated with all of you.
Thank you, Dr. Manoj, for your kind words. With that, we come to the end of the inaugural ceremony of the webinar. Now we'll be hopping on to the scientific agenda. So may we not invite now the chairpersons for the evening, Dr. Dhruvi Hasnani and Dr. Sangeeta Muglekar. And I would request now Dr. Sumita Bansal to kindly introduce the chairpersons. Dr. Dhruvi Hasnani to begin with. Dr.
Sure,
Sumita Bansal.
Sure, ma'am.
This webinar will become a motivation for, other Diabetes India interest groups. I'm sure, the Dhruvi and Rutul will take it very seriously, and so we will have more webinar in other interest group. And
thank you, sir.
When Sangeeta asked me, I told them, Rutul and Dhruvi will join from Diabetes India.
That's nice of you, sir. Thank you so much. Yeah, Sumita, please continue.
So I'd like to introduce Dr. Dhruvi Hasnani. She is consultant diabetologist, Rudraksh Institute of Medical Sciences, HOD, Clinical Research, RIMS, Ahmedabad, Treasurer, RSSDI, Gujarat Chapter, Faculty of National Diabetes Educators Program, speaker at numerous international and national conferences, author to international and national publications and consensus guidelines, editorial board member, Journal of Clinical Diabetology, reviewer for Pediatric Diabetology Journal and Journal of Diabetology, Journal of Pediatric Endocrinology and Metabolism, International Journal of Diabetes and Technology, American Diabetes Association Abstracts, investigator for clinical trials also. And she has won many awards. She is a winner of Torrent Young Scholar Award for Diabetes, Rising Star Awards at DiCareCon, JPEF, Dear Diabetes Academy, International Congress of Obesity, Woman of Eminence Award by Fox Story, Femina, Times Healthcare, TV9, and Early Career Physician Award by American College of Physicians. So I welcome Dr. Dhruvi Hasnani, our first chairperson.
Thank you so much.
Now I would like to invite our second chairperson, Professor Dr. Sangeeta Muglekar. She did her MDS in Periodontics in 1992 from Government Dental College, Mumbai. She has a teaching experience of around 32 years. She is a member of Board of Studies, Bharati Vidyapeeth, Deemed University, Pune. Examiner for MUHS, Bharati Vidyapeeth, Pune University, Baba Saheb Ambedkar University, Rajiv Gandhi University, Pravara Deemed University, Goa University. She has 60 publications in various national and international journals. She has been the author for chapters in 2 periodontology textbooks. She has been as invited guest speaker and chairperson to several national and international conferences, regional supervisor for National Oral Health Survey and Fluoride Mapping 2002 for the state of Maharashtra and Goa. So I welcome you, Professor Dr. Sangeeta, ma'am.
Thank you, ma'am.
संगीता जी आपको अनम्यूट करना पड़ेगा.
Sorry. Dr. Dhruvi, could you please introduce the first speaker of the evening, Dr. Anurag Satpathy, please? Nirav, can we have his bio sketch?
Thank you so much. First of all, thank you to Banshi sir for recommending my name. Thank you, Sangeeta ji, for having us on board, and congratulations to the whole group of the oral health, diabetes India interest group. I have the pleasure of inviting our very first speaker, Professor Dr. Anurag Satpathy sir. He is a professor in the Department of Periodontics and Oral Implantology, and also is in charge of the Integrated Department of Oral Implantology at the Institute of Dental Sciences at Shiksha O Anusandhan University, Bhubaneswar. He graduated from the Bharati Vidyapeeth Dental College, Pune, and did his post-graduation from SDM College, Dharwad. He's an ardent researcher, speaker with research interest in the tissue regeneration, biomaterials, periodontal medicine, platelet concentrates, and soft computing. He has over 100 index publications with close to 700 citations and has consequently featured in the AD Scientific Index 2023 by the Stanford University for the third year. He was awarded his PhD in dental sciences for his pioneering work on biomimetic textured GTR membranes. He has filed 2 patents, one of which has been granted, and one has contributed as a lead author in the book chapters with Springer Nature and Elsevier's publication. So a wonderful CV we have, and we look forward to hearing you, sir.
Thank you very much, Doctor. At the outset, may I share the presentation?
Yeah, please.
Okay. Yes, share. Is the screen visible?
Yes, it is. Yes.
Yeah, thank you very much, Dr. Dhruvi, for a wonderful introduction. At the outset, let me thank Diabetes India for giving this opportunity, and Dr. Sangeeta for being inspiration. I have my teacher, Dr. Sangeeta, who was my teacher in Bharati Vidyapeeth, and also a wide panel of doctors from both the dental and the medical side. Well, today we are speaking, we are sharing information on diabetes, and the focus is on evidence based on the current literature. Now, going forward, this is what we would want to see: a very healthy mouth. But the sad part is that we often see patients who do not brush properly, and that is where we land up in trouble. So just for a little introduction for our participants from the medical side, that when the oral hygiene is not maintained, it leads to accumulation of dental plaque, which leads to inflammation. And when it is untreated, it leads to a destructive disease. Now, this is something that we do not want. Scientists do see this every day in and out. However, the fact that many of the medical practitioners counterpart are unable to see this on day in and day out because probably of either the patients not complaining on their part, or maybe a neglect on the part of peeping into the mouth. But we have known that there is an association between a periodontal disease and the systemic disease, and top of the chart is diabetes mellitus. Now, today we have irrefutable evidences that both of them are connected. And we know that this connection is through the microcosm which is in the subgingival area. Now, in the subgingival area, we know that when the plaque accumulates, there is inflammatory cells which are growing, which leads to an increased inflammation, and that leads to bacteremia. Now, this is a present accepted mode of communication between the oral and the systemic route, and both sides of the story is accepted. That means that the relationship is bidirectional. What happens in the microvasculature of the periodontal tissues is actually reflected in the systemic route. So if you look from the diabetes mellitus part to the periodontal disease part, there is a connection, and this is literature, and this is something that we have known, and same is true from the periodontal disease part to the diabetes mellitus. Now, today I'm going to nest a few evidences which are current, and that is the whole idea that we know the literature that they are both connected, but what does the current evidence show? So, if you look at the gingivitis part, the effect of the hyperglycemia is it shows that without even dental plaque initiation, there could be initiation of the inflammation. And also known are the advanced glycated products and the receptors which come into play. There is a higher prevalence of gingivitis in patients who have hyperglycemia. Also, the higher form of the disease, that is periodontal disease, periodontitis, whenever there is hyperglycemia in the microgingival microbe, and that is also seen that the kind of circulating cytokines and the biomediators which are present in the local environment also rapidly increase, and they are more intense. But what is more important is that it is the hyperglycemia severity which is more linked, and not the diagnosis of the diabetes mellitus per se. And that is where we need to focus, that just because somebody is labeled as diabetes does not mean that there would be a concomitant periodontal disease, but what we need to see that the hyperglycemic status, whether it is maintained or it is not. So what does the evidence suggest? Now let us look at some of the studies. Now, if you look at this study, a bidirectional association, periodontal disease and diabetes mellitus, a systemic review and meta-analysis. Now, the research question on this was, let me just take it down here. Is there an association between periodontal disease and diabetes mellitus? Now, this is a 2021 paper, and if you look from the side of the periodontal disease causing diabetes mellitus, the incidence of diabetes mellitus was 1.26 times. And also from the other side, there's a lag here. If you look at the incidence of periodontal disease or periodontitis in diabetes, that is 1.24. So the meta-analysis suggests that there is an evidence that there is a higher risk ratio of the incidence of both disease whenever the other disease is present. That means the risk of having a periodontal disease in diabetes is also higher, more than 1, and the same is true for the other side. If we look at the relationship of the periodontal index score, there is a non-linear trend. An increase in the incidence of diabetes was observed after a CPA score of greater than 3. Now, this is a periodontal index which tells us how severe is the periodontal disease. Now, when the score rises more than 3, as you can see, there is a steady state increase in the risk ratio of diabetes. There is another relationship seen, as you can see, that when there is an increase in the depth of the periodontal pocket more than 3 millimeter, then also there is a non-linear relationship of the risk of diabetes. So both, when we look at the parameters of periodontal disease, whether it is index of the periodontal disease or there is probing depth, in both cases the risk of the diabetes increases. In another study, this study does poorly control diabetes mellitus increase the chance of periodontitis developing and spreading. They found that 70% or higher, this is a 2023 study, 70% higher chance of developing periodontitis than those without diabetes with a risk ratio 1.86. So these are the latest evidences which are endorsing the fact that there is a connection between periodontal disease and diabetes mellitus. Now, this study effect of periodontal treatment. Now, we now know that there is a association, but whether there is effect of periodontal treatment in patients with periodontitis and diabetes, what does it say? It says that SRP, which is scaling and root cleaning, it is a very simple form of treatment which we do in a dental practice. It has an impact on the metabolic control and reduction of systemic inflammation in patients with type 2 diabetes. Looking at another evidence in type 1 diabetes. Now, lot have been, very less studies have been done on type 1 diabetes and periodontitis, but it has been seen that the proportion of patients affected by the periodontal disease is more than doubled in subjects with type 1 diabetes in comparison with the non-diabetic. That means the relationship holds true both in type 2 diabetes as well as type 1 diabetes. Now, here is evidence on the relationship where it says that there was a significantly worse periodontal status. If you look at the diabetics and you try to see the periodontal status in those patients, you will see that a 0.61 millimeter deeper periodontal pocket or a 0.89 millimeter higher attachment loss is seen in those, and almost more than 2 teeth are lost in the diabetes as compared to the non-diabetic. In 2021, there was this study on dental implants. Now, not only periodontal disease, now the association has also been seen in Dioh, and then there is again a biofilm associated inflammation. So in those patients who have dental implants, does diabetes play a role? Yes, it does. It has been seen that as the HbA1c level increases, the bleeding of the tissues surrounding the implants also increases, and bleeding is an indicator of inflammation. And higher the bleeding, there is more chance of the breakdown of the tissues and failure of the implants. Looking at the relationship of the periodontitis and microangiopathy, very few studies about the microangiopathy in type 2 diabetes mellitus. And what did they found? They found that periodontitis was associated with increased risk of type 2 diabetic microangiopathy, in which there was diabetic retinopathy and diabetic nephropathy, which was associated. However, they did not find any association with diabetic neuropathy. Now, this was true when there was a subgroup analysis of this meta-analysis. They found that whether the subgroup analysis was done in Asians or North Americans, it was significant. Now, periodontitis treatment, both surgical and non-surgical treatment, what is the effect on glycemic control? Now, in 2023, this is the latest evidence that we have. It shows that there is an improved HbA1c level with an odds ratio of minus 0.024, which is towards the improvement side. Now, looking at again, this is whether the periodontal therapy has any role on the insulin resistance with adults. It showed that NSPT, which is non-surgical periodontal therapy, significantly reduced the HOMA insulin resistance when compared with the pre-intervention data or when there was no treatment. That means now we know that periodontal treatment definitely has a significant relationship or association when compared to both the surgical or non-surgical therapy in bringing down the HbA1c level and improving the glycemic status. So in 2023, this is a study where all the studies, systematic reviews were compiled together and an umbrella review. From 2010 to 2021, they studied a lot of studies, and there was 27 studies which were included, and they found that a mean difference of minus 0.49% and minus 0.38 HbA1c level reductions were seen for both 3 to 6 months post-treatment level. So not only few systematic review and even the umbrella review, which shows that yes, there is a definite improvement of the HbA1c level for in those patients who have a poorly moderated glycemic index and the periodontal therapy is done. Now, one of the latest study in 2024 with the Basin network, they tried to see whether any addition of any concomitant therapy or any drug improved the HbA1c level. Yes, the answer is that when we include metronidazole or alpha lipoic acid in adjunct to the NSPT, that is non-surgical periodontal therapy, there was a change or a definitely significant clinically meaningful HbA1c levels, and both the probing depth reduction. So all these evidences do tell us that yes, there is a growing body of evidence that yes, if we are able to send these patients for periodontal therapy and we are able to maintain the periodontal therapy, then definitely we will be able to decrease the HbA1c level. And that is what is our goal. Once the HbA1c levels are controlled, there is a concomitant improvement in the periodontal health also. So they go hand in hand. And the treatment is very simple. That there is a accumulation of plaque and calculus, which the patients notice and do not notice. And if we are able to identify them at an early level and refer them to a dental practitioner, and we do a simple procedure like scaling, which takes around half an hour or so. Sometimes it may take multiple sessions, but right from the first appointment itself, there is a reduction of the inflammation around the tooth, and the tissues start bettering up. There is a beginning of health, and there is an improvement of HbA1c level. So this is with the limited time that we have. I have nested these evidences together in order to update. And going further, we have Dr. Rutul Goklani, who will be speaking on diabetes cardiovascular disease, and Professor Jayanti, who will be talking about the cardiovascular disease and the periodontitis nexus together. Then we have Dr. Purvi, who will be speaking about the diabetes and pregnancy, and Dr. Pauline George on periodontitis and adverse outcomes of the pregnancy outcomes. And finally, Dr. Anupam Dekka, who will be summarizing the systemic nexus. So this is all lined up, starting from what I have presented, and over to Sangeeta ma'am. Thank you.
Thank you, Dr. Anurag, for the opening up the gates for the webinar and beautifully created and setting up the platform. So I would now like to invite Dr. Sangeeta Moglekar ma'am to kindly introduce the next speaker for the evening, Dr. Rutul Goklani, please. Could we have his bio sketch?
Yes. Thank you, Dr. Sangeeta. And congratulations to Dr. Sangeeta Dheer madam and DIOH team for such a nice initiative, much needed initiative to bridge the gap between the medicine and dentistry. I have the honor to introduce Dr. Rutul Goklani. He is a consulting diabetologist. He is a managing director at ASC Diabetes Center. He is fellow in diabetes from Apollo Hospitals and Liverpool, UK Diabetes India. He is postgraduate in diabetes from Czech Republic, Greece EASD, certified in diabetology from RSSDI. He is a national coordinator, D-Genius Group for Diabetes India. He is a founder, DiaConnect PhD, Diabetes and Pregnancy Conference. He is a governing council member, Diabetes in Pregnancy Study Group of India. He is a member of RSSDI, EASD, ADA, ISPAD. He is also a teacher for NDEP and PHFI. He is a regional and national faculty for various conferences. He is also a member of RSSDI, Diabetes India, international member of EASD, IDF, ADA, ISPAD. He has humble number of national and international publications. He is also expert in managing technology in type 1 diabetes mellitus and GDM. He is a principal and co-investigator in various clinical trials and observational study. We are honored to have you, sir. Thank you. Over to you, sir.
Thank you very much, Dr. Sangeeta Moglekar, for kind introduction. And duo of Dr. Sangeeta is there. Thank you, Dr. Sangeeta Dheer, for having us here and giving us the chance on such a wonderful topic. Really, our cross faculty talks we really need, and we can improve overall care of our patient, whether it is periodontal diseases or diabetes. It definitely, the evidences we already have seen from Dr. Anurag. What a wonderful lecture. All the recent advances he showed, and I'm really impressed that how it is impactful to treat periodontal disease and vice versa to improve overall care. So thank you very much, Diabetes India, Dr. Bansi Sabu sir, Manoj Chawla sir, and everyone for having me here. And may I upload my slide now?
Yes, please.
Yeah, thank you. So my today's topic is diabetes and cardiovascular disease, and my flow of today's topic and objectives are to explore links between metabolic and cardiovascular disease, discuss the need for more holistic approach to diabetes care, particularly comprehensive vascular risk control, present latest evidence for outcomes, benefits of glucose lowering drugs, and discuss the practical and proactive implementation of diabetes and cardiology guideline recommendation. So diabetes and cardiovascular disease, these are the deadly duo. So they go hand in hand, we know. The risk of cardiovascular disease in diabetes mellitus follows a slope, and this is very steep upwards slope that we know, and the severity of this slope depends on combination of multiple risk factors, especially the risk factors like hyperlipidemia and obesity. This three of risk factors combined together with diabetes and cardiovascular disease, then definitely it causes mortality in very bad shape. So poor control of most cardiovascular risk factors have been observed in diabetic population, and diabetic patient had 10% higher risk of cardiovascular disease, 53% higher of myocardial infarction. This is one of the highest number which is associated to diabetes. 58% of higher risk factor of stroke, and 12% higher risk of heart failure than non-diabetic population. So if you compare it to non-diabetic population, overall cardiovascular disease are higher in our diabetic population. So cardiovascular disease is the major cause for mortality in diabetic patient. The overall risk factor in diabetic patient for cardiovascular mortality rates varies from 1 to 3 in males and 2 to 5 in females, as in comparison to non-diabetic patients. So it is around 3 to 5 times higher risk of cardiovascular disease in diabetic patient. Throughout USA, cardiovascular mortality rate for diabetic adults showed a rise in the risk of heart attack and myocardial infarction around 1.8% larger than those who have non-diabetic patients. Also, if we see the traditional way of looking at cardiovascular disease, when we look at cardiovascular disease, we see at higher cholesterol levels, higher blood sugar level, along with hypertension and thrombotic tendency, which leads to accelerated atherogenesis, and it increases myocardial infarction, cerebrovascular accidents, and peripheral arterial disease. But if you see the newer way of seeing cardiovascular disease is hyperinsulinemia, renal SGLT2 activities, and glomerular hyperfiltration rate, as well as tubuloglomerular feedback, which also increases salt intake. Along with this, it increases sodium and glucose retention, ultimately leads to intravascular and interstitial volume. And this increased volume status increases hemodynamic and glomerular stress, which leads to heart failure and kidney disease. So along with traditional risk factors leading to newer insights in related to obesity, leads to multiple risk factor of cardiovascular disease and multiple complication of cardiovascular diseases. So metabolic, cardiovascular, and kidney disease, if we see as whole, atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality in persons with diabetes and largest contributor to direct and indirect cost of diabetes. So diabetes increases the risk of atherosclerotic cardiovascular disease, and ultimately it leads to increase in overall cost of treating diabetes. If you see the heart disease, patients with type 2 diabetes have more than twice the risk for developing heart failure and worse cardiovascular outcome and hospitalization. Also, the prognosis that patients without diabetes. And now, if we see at the chronic kidney disease, most of our patients, if we see, they don't die of kidney disease, but definitely they die of cardiovascular disease. So to reduce the cardiovascular disease, we need to reduce the burden of chronic kidney disease, and for that matter, we need to reduce overall, we need to have good glycemic control as whole. So risk factors and mechanisms, if you see, we have already seen atherogenesis, heart failure, obesity, and untargeted pathways, which are leading to multiple cardiovascular risk factors. So multifactorial approach, which is very important in our type 2 diabetic patients. So type 2 diabetes doubles the risk of atherosclerotic cardiovascular disease, but risk begins in pre-diabetes phase. So nowadays we are seeing newer data from IDF and as well as our ICMR that pre-diabetes population is more than our diabetic population. And usually our physicians are maybe our dentists or even our diabetologists, they neglect the situation of pre-diabetes in many of the cases. So we leave them by saying that, yes, you may get diabetes in next few years, have more focus on your lifestyle modification. But yes, we need to take it very seriously as the risk of atherosclerotic cardiovascular disease increases during pre-diabetes stage only. Blood pressure control and LLT, that is lipid lowering therapy, outweigh glucose lowering for cardiovascular event prevention and treatment targets identified decades ago. So the first thing that we need to take care is cholesterol level. Definitely we need to treat our LDL level at best, and we should try to achieve our LDL level less than 70 in any case of our diabetic patient. Blood pressure should be less than 140/90 for our most of the patients, and glycemia, if you see HbA1c, it should be between 6.5 to 7. And we may relax in few of the subgroups where already established cardiovascular disease or chronic kidney disease, where we should target it around 7.5. So if we see cardiovascular disease prevention in clinical practice, patients with type 2 diabetes in ESC guideline according to 2021, we should target HbA1c less than 7%. If our patient has established cardiovascular disease or target organ damage, then systemic blood pressure should be less than 140, and if possible, try to achieve less than 130. And LDL cholesterol, we should target at least less than 70, or if 50% or more, then we should try to reduce it by 50% less. And stop smoking and lifestyle recommendation. This we should given in written format to all our patients. SGLT2 and GLP-1 receptor agonist has shown superb data in last few years. Even this is the slide of 2021, but recent guidelines of 2023 suggest that we should put it even before metformin if it is possible. So GLP-1 receptor agonist we should try in our post-stroke, and SGLT2 inhibitors for our patients with to prevent hospitalization due to heart failure and chronic kidney disease. So which drug for which patient? That ADA in 2021 has already explained, if patient has established heart failure, then SGLT2 should be first choice with proven benefit in this population. If patient has CKD, then definitely SGLT2 should be preferably used. And GLP-1 receptor agonist also has shown benefit, but yes, SGLT2 should be the first choice. along with maybe metformin or without metformin. And if patient has established atherosclerotic cardiovascular disease, then GLP-1 receptor agonist should be the first choice, along with SGLT2 if possible, to combine together. So patient preference is also the important thing, where SGLT2 inhibitors are oral tablets and GLP-1 receptor agonist, except semaglutide, are most of them are injectable. But now we have once weekly injections of GLP-1 receptor agonist like dulaglutide, even semaglutide. So we should try or ask our patient which they prefer. So a daily oral formulation of semaglutide approved since 2021, and in India it is available since 2022. So adjusting other medication and antihypertensive, SGLT2 inhibitors cause natriuresis by blocking SGLT2 mediated glucose reabsorption in proximal tubule, and systolic blood pressure reduction is around 3 to 5 mmHg. Avoid SGLT2 inhibitors in patients with hypotensive or hypovolemic. Also, the patients who have higher tendency of fungal genital mycotic infection. Stop or reduce antihypertensive medications, including diuretics, as need to restore normal blood pressure. So 2023 ESC guidelines from the management of cardiovascular disease in diabetic patients, they all suggest that along with metformin, or even without metformin, you may use GLP-1 receptor agonist and SGLT2 in our cardiovascular disease patient. So with this, I'll summarize, and link between metabolic, cardiovascular disease and kidney disease are there. So risk factors and mechanisms and prognosis we should take in consideration. Latest evidence for outcome benefits of novel glucose lowering agents like GLP-1 agonist and SGLT2 inhibitors should be considered as first choice. And need for holistic approach to diabetes care, where a comprehensive vascular risk control should be also considered in all of our patients, and putting data into practice that gives many things, and guidelines recommendation for sick day rules, adjustment in other diabetes medication and antihypertensive also should be our first priority. With this, I conclude. And if we have the questions, we may discuss in the panel discussion or as our moderator suggests.
Thank you, Dr. Ruttal, for your excellent presentation. We now move on to the next speaker. Maybe invite Dr. Muglikar to kindly introduce the next speaker, Dr. Jayanti, please. Can we have a biosketch? Neerav, can we have Dr. Jayanti's biosketch? Yeah.
Yes. I have honor to introduce now Dr. Jayanti. She is a professor and head Department of Periodontics, M.R. Ambedkar Dental College and Hospital, Bangalore. She graduated from Government Dental College and Research Institute, Bangalore, and post-graduation MDS Periodontology from M.R. Ambedkar Dental College and Hospital, Bangalore. She has done certificate courses in implantology and aesthetic dentistry from reputed institutes. She has 26 years of teaching experience and is postgraduate guide. She has guided and trained 28 plus postgraduate students and certification course students. She has recently also been recognized as a PhD guide. She has been an eminent teacher, and her immense interest in research activities is noteworthy. She has more than 22 original research articles to her credit, which are published in index national and international journals. She is a member of the review board in Journal of International Clinical Dental Research Organization. She has presented more than 10 guest lectures and chaired scientific sessions in various state and international conferences, CMEs, and seminars. She is also affiliated to Bangalore Academy of Periodontology, Indian Society of Periodontology, and Indian Journal of Dental Research. She is a prolific reader and keen to adopt an innovative, simple, and understandable method to teach the students, and encourages publishing various original research articles. Over to you, Dr. Jayanti.
Dr. Jayanti, please unmute yourself.
Hello.
You may start, ma'am.
Can I share? No,
Yeah.
I cannot see the screen. That is the reason. I have shared.
So, you are still to share it. We are not able to see your presentation.
No, I have given to Sumida also.
So you want us to share it or you are sharing from your end? Please confirm.
Yeah. No, I am not able to do that because it is jumping.
Okay.
Sumida can.
Dr. Sumeda?
Yes, ma'am.
Now you need to just forward me her presentation because I was not aware that she is not sharing it from her end. Please forward me so that I can quickly give it to the event team.
Yes, ma'am, definitely.
Neerav?
Ma'am, I forwarded it to you.
Yeah. Neerav? Neerav, I'm forwarding the speaker's presentation to you. Kindly just share it on her behalf, please. That has reached you. Just give us 2 minutes to just get it sorted. Neerav, it has reached you.
Good evening. Actually, this is a great initiative where the medical and dental faculty are coming together in the single platform and sharing their knowledge. It's really wonderful. And I am really proud to be a part of this. Today, I'll be briefly explaining about the periodontitis and cardiovascular risk. Let us understand the mechanism linking periodontitis and cardiovascular disease. There are two pathways, that is, one is direct pathway and indirect pathway. The direct pathway says that periodontopathogen directly acts on the endothelial cell, and the common microorganisms which are detected are Streptococcus mutans, and other bacteria in the coronary arteries which are detected are aggregated bacteria Actinomycetium comitans, Tenorella forticius, Prevotella intermedia, Porphyromonas gingivalis. All these are assessed through the PCR assay. And the second mechanism which is proposed is indirect pathway, where periodontitis induces an inflammatory response where the inflammatory mediators like interleukin 1, interleukin 6, 8, TNF-alpha, which are linked to atherosclerotic vascular diseases. And also there is production and emission of fibrinogen and C-reactive protein. Similarly, bacterial lipopolysaccharide elicits strong immune response. These components influences atherosclerosis by acting on endothelial cell, which increases the oxidative stress and harmonizes the lipid metabolism. Next. This is the flow chart wherein you can see the relationship between periodontitis and cardiovascular diseases. The same thing is explained, direct pathway and indirect pathway. In direct pathway, you talk about the bacteremia because of the bacteria which are entering into the bloodstream. And in indirect pathway, the endotoxins and the enzymes which are released by the bacteria are released. And these both pathways are released and there is inflammation and atherosclerosis. Next. Coming to the epidemiological evidence, which includes, next, clinical studies and systematic reviews. I think I can have the control. Yeah, can I have the control?
Jayanti ma'am, you need to tell a command to the event team because you have not shared the presentation, so you cannot.
Yeah.
So do it.
Okay,
then.
okay.
Yeah,
Yeah, please. I am not able to. Yeah, next. This is a longitudinal study where, means you can just scroll on. Longitudinal study by Beck and co-worker. They conducted a study on 921 men who did not have coronary heart disease. And among them, 207 men developed coronary heart disease during a period of 18 years. And the odds of suffering a vascular event or CHD were higher in the individuals who had periodontitis. Next. Coming to the next study, that is, we have next cross-sectional and case control study by Herbis. He has analyzed the NHANES data and he found out that the likelihood of suffering an MI was increased when there was periodontitis, which is in the severe form. So this study confirms the link and an absolute association among increased severity of periodontitis and cardiovascular disease. Next. And another study, cross-sectional study, next. By Jenko and co-worker, they investigated the link between certain subgingival periodontopathogen and myocardial infarction. They confirmed that for myocardial infarction patient, the odds ratio for the presence of teneruloforthisis was more, and for P. gingivalis also it was more. And this study supports that specific periodontopathogenic bacteria are found in periodontal disease and are also associated with myocardial infarction. Next. Coming to the systematic review to meta-analysis, 9 cohort research compiled by Jacket and et al. Here they suggest that for future CVD and cyclic vomiting syndrome episode, periodontitis is a determined risk factor and had a 19% risk for advancing such events. And also, patients under the age of 65 were at high risk. Next. The observational study, again, it is a meta-analysis study where 215 epidemiological studies were included and the pooled all odds ratio was 2.35. And this study concluded the risk of developing cardiovascular disease, which was found to be significantly higher in subject with periodontal disease compared to without periodontal disease. Next. And this is the latest study where the consensus report by the European Federation and World Organization of Family Doctors. This evidence, in their evidence, they have compiled the epidemiological study and they proved that periodontitis patient exhibited significant atherosclerosis. Next. And there is a robust evidence for positive association between periodontitis and coronary heart disease and stroke. And in another study, 30 cohort studies were included, and they have concluded that there is an association of periodontal disease with the risk of major adverse cardiovascular events. Next. Coming to the interventional studies, next. Boquero et al. who actually they perform non-surgical periodontal therapy, and they've seen that there is reduction in the coronary heart risk markers. Next. Next. And in another study by Claulla et al., they monitored and assessed the patient for 6 months to find out the effect of periodontal treatment on cardiac risk marker. And they found that C-reactive protein and triglyceride level were lowered after the treatment of periodontal therapy. Next. And in one more study where they have implemented the oral hygiene practice. Next. In a large longitudinal research, they included 161,000 individuals, and they asked them to maintain good oral hygiene with regular toothbrushing and professional method, and they found out that there is reduction in the cardiovascular risk. Coming to the comprehensive analysis and synthesis of relevant study indicated that periodontal treatment decreased the biomarkers which are related to cardiovascular as well as the periodontitis diseased individual. Next. To conclude, overall, the study suggests a significant correlation between periodontitis and cardiovascular risks with shared risk factor, epigenetic influence, and inflammatory processes playing key role in the association between these two conditions. Understanding this mechanism is essential for developing targeted intervention to improve oral and systemic health outcome in individuals with periodontitis and cardiovascular disease. Periodontal screening in specialized medical care setting should be a component of the management of cardiovascular disease. Next. Periodontist, cardiologist, and patient should be informed on the potential negative influence of periodontitis on cardiovascular development and its complication, as well as on the positive impact on periodontitis treatment on cardiovascular status. Thank you.
Thank you, Dr.
Within the stipulated time, no, I have done, but technical issues were there.
It's okay,
Sorry for that.
Not at all, not at all. Thank you so much, ma'am, for your lovely presentation. We now move on to the next speaker of the day. May I please request Dr. Dhruvi Asnani to kindly introduce Dr. Purvi Chawla, please.
Hello, good evening. And we've got a wonderful lineup of faculties who've been speaking so well and enlightening us with their knowledge. It is a pleasure for me to introduce Dr. Purvi Chawla, ma'am. She has been a constant motivation to me also. She's a consultant diabetologist and director at the Leena Diabetes Care Diabetes and Beyond at the city of Mumbai. She's a co-investigator and sub-investigator for multiple global and national clinical trials. She has been the immediate past president for the Santa Cruz Medical Social Association. She's a scope certified physician. She has managed so wonderfully the RSSDI social media cell member and as well as the Defeat Diabetes core team. She's the executive committee member for AERO as well as the ACP. She's the social media editor for the International Journal of Diabetes in Developing Countries, the founder and chair for Diabetes Research and Solutions, not just for 2022, but 2023 and the upcoming WCPD in 2024. She's the co-chair for Diabetes and Women Interest Group, Diabetes India. She's received numerous awards to her name, the RSSDI USV Best Innovation Awards in Diabetes Care During Challenging Times, the DiaCareCon Award 2021, the JPEF USV Diabetes Tech Innovation Award, the ACP Best Indian Woman Educator Award, True Wealth, Health and Wellness Award for Courage, Compassion and Commitment in the COVID Care. She's the reviewer for national journals, the IJDDC as well as numerous other journals. She's the organizing chairman for Diabetes Research and Solutions, the scientific chair for Women and Diabetes, trainer for courses like NDAP, as well as instructor for insulin pump and CGMS use at the Leena Diabetes Care Center, Mumbai. She's the ex-leader and consultant for clinical development and medical affairs, diabetes and metabolic disorders at Piramal Enterprise Limited, new chemical entity research and internship at the US FDA. I have the privilege to know her since quite some years and learn from her. Over to you, Purvi ma'am.
Thank you, Dhruvi. I think we are a great team because you take so much trouble in introducing me that I am embarrassed actually. Anyway, thank you very much. This has been a fantastic initiative. And like Dr. Banshi sir mentioned, Dr. Sangeeta, your enthusiasm and this drive is going to motivate a lot many other groups which need that stimulation. And thank you, Dr. Bansal, for coordinating everything and planning everything so well. So without much ado, let me start sharing the screen. You've asked me to speak on diabetes and pregnancy. I've actually stuck to only the pointers that you gave me because it's a very vast topic and nearly impossible to finish in such a limited time. But we'll just go through the highlights because there are some important risks associated with this, and this is not a clinical entity to be taken lightly. So let's see how and where all this is headed. But a pregnant woman with, complications, metabolic complications, and oral health complications is not something that you really want. So hence, this initiative is going to be helpful. The prevalence of hypoglycemia in pregnancy, which is often called as HIP, is somewhere between 16 to 17% worldwide and is only growing. In fact, 1 in 4 live births in the IDF Southeast Asian region itself is affected by hypoglycemia in pregnancy. And every year, GDM complications or gestational diabetes mellitus complicates nearly 4 every year in India. So this is an alarming and exponentially increasing non-communicable disease problem. And let's see what the impact is. Now, WHO and FIGO have very nicely simplified this entire term of hypoglycemia in pregnancy. It tends to include pre-gestational diabetes, diabetes in pregnancy, which is DIP, and GDM, which is gestational diabetes. So women with known type 1, type 2, or other forms of diabetes before pregnancy come under pre-GDM. Diabetes in pregnancy is purely hypoglycemia that's detected for the first time during pregnancy and meets the criteria of diabetes in the non-pregnant state. And this is typically diagnosed in the first trimester of diabetes. And gestational diabetes is, again, hypoglycemia detected in the antenatal period, but it can be any time, but usually in the second and third trimester and is not expected to persist postpartum. So pre-gestational and gestational diabetes have been beautifully simplified and explained. And DIPSI, which is a diabetes in pregnancy study group of which Rutul is a part of the governing council, they have, defined hypoglycemia in pregnancy or GDM, and that's an important definition for us because in India we follow DIPSI, which is also endorsed by the Government of India guidelines. So manifestation of hypoglycemia in pregnancy, GDM, is defined as any degree of glucose intolerance with onset or first recognition during pregnancy. GDM represents detection of chronic beta cell dysfunction and is considered to be a stage in the evolution of type 2 diabetes. And this really is the concern because it does represent detection of chronic beta cell dysfunction and is indeed the stage of evolution of diabetes. What is the impact? The impact is multifold on the mother as well as the fetus. In terms of the mother, there may be increased preeclampsia, which is associated with increased hypertension. And complications of labor, I've listed all the complications here. And postpartum and beyond, there may be subsequent pregnancies also affected by diabetes. And also there's an increased chance of type 2 diabetes. As far as the fetus is concerned, there is CNS malformations noted with hypoglycemia untreated. There is cardiac fetal programming. There's increased incidence of large for gestational age, increased macrosomia, increased fat mass, and then acute complications like prematurity, perinatal asphyxia, respiratory distress, polycythemia, low iron stores, so on and so forth. But importantly, long-term complications are also very important to note here, which is increased obesity, increase in type 1 and type 2 diabetes, and also increase in metabolic syndrome. Now, the lifetime risk for diabetes increases in women with gestational diabetes. Up to 50% of gestational diabetes women develop impaired glucose tolerance within the first 5 to 10 years of the index pregnancy. And this risk is almost tenfold. This has been noted. And the absolute risk increases linearly through a woman's lifetime. So it's 20% increased risk of type 2 diabetes at 10 years postpartum, 30% at 20 years, 40% as 30, and so on and so forth. It's just exponentially increasing. Now, women with GDM are also at a high risk of premature cardiovascular disease. And this is, again, this was alluded to in the first talk. And this is an important aspect because women with a history of GDM have higher prevalence of metabolic syndrome and increased risk of cardiovascular disease. This again has been reported by Dr. Ratnakaran and group, and many other groups have also studied this. Over 10 years, women with GDM have more non-invasive cardiac diagnostic procedures, simple cardiovascular events, and total cardiovascular hospitalizations after adjusting for age, ethnicity, and comorbidities like preeclampsia and obesity. So this remains a single most important risk factor. Now there is something called as NAFLD or MASLD, which is metabolically associated fatty liver disease or non-alcoholic fatty liver disease. We know this is the most prevalent form of chronic liver disease, eventually increasing cirrhosis and hepatocellular carcinoma also, and becoming the #1 reason for liver transplantation. But due to the increasing burden of NAFLD, early identification and prevention strategies are important. Why am I telling you this? Because NAFLD in pregnancy is associated with adverse maternal and perinatal outcomes, as reported by this study in the Journal of Hepatology. They found that pregnancies with NAFLD nearly tripled significantly from 2007 to 15. But compared to others, patients with NAFLD during pregnancy more frequently experience GDM, hypertensive complications, postpartum hemorrhage, and preterm birth. Thus, NAFLD was considered a high-risk obstetric condition with preconception counseling and pregnancy care very, very important. Now, NAFLD itself is associated with adverse maternal fetal outcomes. The prevalence of NAFLD having increased threefold in pregnancy over the last decade, it was seen that it increases risk for both mother and baby, including hypertensive complications of pregnancy, bleeding after delivery, and preterm birth, warranting good preconception counseling. Now, GDM is also strongly associated with NAFLD. So it has been seen that GDM heralds not only type 2 diabetes, metabolic syndrome, cardiovascular disease, but it was not very clear if GDM increases NAFLD or not. And for that, there was this cardiac study which was undertaken, which was a multicentric study of following young women adults between 18 and 30 years of age, all the way to 25 years. And they looked at and they found that at baseline, compared to women without GDM, those with GDM at baseline, GDM over or developed GDM over study period had higher BMI, HOMA-IR, which is sign of insulin resistance, which is an index which helps us understand the insulin resistance in the body, and also increase waist circumference. And at the end of 25 years, they found that as compared to women without GDM, those with a history of GDM had significantly higher HOMA-IR, incidence of diabetes, and greater parity more than 2. So women with a history of GDM had a more than twofold prevalence of NAFLD compared to those without GDM. So you see, this is the chicken and egg, that NAFLD increases GDM, but GDM equally feeds into NAFLD. And incident diabetes is only found to be mediating pathway between GDM to NAFLD. So the conclusions from this was that GDM becomes an intervening window of opportunity to prevent NAFLD in the future. Now, diabetes also begets diabetes, And again, if you follow the offspring of those born with the mothers having GDM, it's found that they not only have a 4 to 8-fold increased risk of diabetes, but almost 47.2% of diabetes in youth is attributable to the uterine exposure to maternal obesity and diabetes. Now, this is quite significant because here we have the younger population also getting diabetes when the mother had diabetes when they were pregnant with these kids. So this brings us back to the basic principle of Garbha Sanskar, where, we always believed ancient Indian evidence was always existent for, the entire fact that conception and the growth of a child in a mother's womb and its spiritual connection is very strong. And even as the unborn baby is in the womb of his mother, there are 5 things which are fixed, which don't change, is the lifespan, the activities, the acquisition of wealth and knowledge and time of death, but everything else is programmed within the womb of the mother. And this was further scientifically justified and explained by Professor David Barker, who said that the body's susceptibility to lifestyle diseases was actually programmed in the intrauterine life itself. So what exactly is this? This is nothing but the susceptibility to cardiovascular disease, non-insulin dependent diabetes mellitus, and insulin resistance syndrome. It's all programmed in utero. And exposure during this crucial period of development may influence later metabolic or physiological functions in adult life. And adverse environment in the fetal life and early childhood again help to manifest all these adverse conditions. So again, all this is trying to say is when you have the bad uterine environment and then you top it with postnatal environment, which is conducive to the development of these chronic disorders, it's just a perfect storm, and it is going to trigger the setting off of epigenetics, and it will manifest as these chronic conditions. And this is almost permanent because there is imprinting of the genome at the time of the intrauterine time. And I'm just going to show you, I'm not going to the details, but I'm just showing you that several researchers have put forth different theories to explain the same thing. Now, for example, the fetal insulin hypothesis also says that maternal glucose concentrations, they cause enhanced glucose sensing by the fetal pancreas, and it stimulates the fetal pancreas to secrete insulin. And then there is insulin-mediated growth, which impacts the infant's birth weight. Then there is a Pedersen hypothesis, similarly talking about macrosomia, organomegaly, and other conditions along with when there is carbohydrate excess noticed as passing the placenta to the baby. Again, there is a mixed nutrients, Norbert Frankel theory. Then there is the Frankel hypothesis. There's a modified Frankel's and Pedersen's hypothesis, all talking about the same thing, that a woman with history of GDM is at an increased risk of future diabetes, predominantly type 2 diabetes, as is their children. And this is the intergenerational or the transgeneration transmission of non-communicable diseases. So here NCDs are adversely impact maternal health, but then poor maternal health itself increases the risk. And again, this is the same thing, but in a more graphical way, it impacts every organ of the body and the offspring and also early childhood. So a healthy infant would lead to a healthy child, but with all these epigenetic changes or modifications, we have an obese child, which leads to a pre-diabetic child, and then a child with diabetes. So this is the developmental origin of health and disease, the Dioh hypothesis. Again, all this leads to not only behavioral, but neurophysiological defects in the offspring, which manifest at different stages in the child's life. And again, there's altered energy, appetite, adipocyte metabolism, and this is sowing the seeds of childhood obesity, again, which is the common soil, like our chief guest also said, to early onset gestational diabetes, metabolic syndrome, cardiovascular disease. So this is that entire vicious cycle of diabetes and obesity, also responsible for lung development and impacting lung development and also respiratory diseases. But the good part is that if you treat gestational diabetes, and this is a systematic review and meta-analysis, which shows that treating and controlling sugars during pregnancy will lead to better outcomes. Again, the risk factors, the age, increasing age, pre-pregnancy overweight or obesity, a family history of diabetes or even gestational diabetes, polycystic ovarian syndrome, previous abnormal glucose tolerance, poor obstetric outcome, high-risk ethnic groups like Indians and Asians, and previously delivered a big baby. All these are risk factors. So the recommendation is that the fasting blood glucose be maintained at 90 milligrams per DL and post-meal levels at less than 120 milligrams per DL, HbA1c of less than 6%. In terms of time in range, again, a lot of research is still ongoing, but in type 1 diabetes, it is fairly adequate to say that the time in range should be maintained as more than 70% or so, with minimal time spent below range. So thus, GDM is the window of opportunity that we are looking at to intervene and prevent all these conditions. And we as clinicians are afforded with this rare opportunity to alter the natural course of disease and change the future health of women and their offspring. So much so that our god of gestational diabetes in India, Professor V. Seshaya, clearly says that for a diabetes-free generation, focus on the fetus for the future. So thank you very much again, all of you, for this patient hearing and this opportunity.
Thank you, Dr. Purvi. As always, it was a wonderful hearing you once again. And next we are requesting Dr. Sumedha Bansal to kindly, Dr. Sangeeta Mudlikar to kindly introduce Dr. Pauline George. Now, apparently, Dr. Pauline is traveling, so she's unable to log in. So she has sent the recorded version. So, Neerav, could you please start that after her introduction? Dr. Mudlikar, please introduce. Dr. Mudlikar, please introduce the biosketch first.
Yes. Dr. Pauline George. Yes. Dr. Pauline George is Professor, Department of Periodontics at Krishna Devaraya Dental College, Bangalore. She has 24 years of teaching experience. She graduated from BDS from Government Dental College, Bangalore, and MDS from CORDS, Davangere in 2000. She maintains a keen interest in perioplastic surgery and has conducted various research and hands-on courses in the same. She has presented a poster discussion at Europerio 2018, Amsterdam, Netherlands, Europerio 2015, London, UK, and the International Conference of Special Care Dentistry, Chicago, USA in 2010 and 11. She is trained in implantology from the University of Manitoba, Canada, and procured a certificate in oral rehabilitation of patients with special needs from National Institute of Health, USA. Under her guidance, the prestigious ICMR has granted Senior Research Fellowship Program to a research program. She has been actively managing a general dental practice with special emphasis on periodontal therapy for the past 23 years. Over to you, Dr. Paul.
Neerav, can we have a presentation?
And my topic for today is periodontitis and adverse pregnancy outcomes. So we are all very familiar with the adverse pregnancy outcomes, mainly low birth weight, preterm birth, small for gestational age, preeclampsia, gestational diabetes, fetal morbidity and mortality, so on and so forth. What we are here to see today is what is the relationship between pregnancy and periodontitis. As the hormonal fluctuations increase, the levels of progesterone and estrogen increase during pregnancy, they have a profound influence on the periodontal tissues because of the presence of receptors in these periodontal cells for hormones. Due to this association, what we see is a profuse gingival inflammation in almost around 1/3 of the pregnant ladies. Also, sometimes this isolated angiogranuloma, as you can see in the image here, is also frequently seen in pregnant individuals. We don't have much clinical evidence about periodontitis and pregnancy. Now, what we are mainly concerned here is not how pregnancy causes periodontal disease, whereas the reverse. When periodontitis is present, can it lead to adverse pregnancy outcomes? So in this context, what we can have is 3 types of association. Absolutely no relationship at all. They are 2 different entities and they are coexist probably as random coincidences. Or there may be an association where one is a risk factor for the other. Or the third option is there may be a causal relationship wherein periodontitis can actually cause advanced pregnancy outcomes. Do we have clinical evidence in that regard? And if so, then intervention plays a very major role. With that in mind, what we are focusing today on is if periodontitis can have a focal infection pathway. There are 3 postulated pathways. One is metastatic infection, second one is injury, and the third one is metastatic inflammation. So by metastatic infection, we mean that periodontal pathogens from the periodontium via the hematogenous route reaches the fetoplacental unit and thereby causes adverse pregnancy outcome. Or due to the presence of these pathogens and their byproducts, there may be damage to the fetoplacental structures, thereby leading to impaired growth and adverse pregnancy outcomes. Or the third pathway is the periodontal pathogen and its byproducts spill over into the vascular system that reaches the liver and initiates a secondary inflammation, and that in turn causes some kind of pro-inflammatory cytokine to be released into the fetoplacental unit and thereby producing adverse pregnancy outcome. So since this is a spotlight on clinical evidence, we're going to see more about that. So when we are saying that it is a metastatic infection, during periodontitis, there is increased vascularity and therefore there is a high possibility for bacteremia and the leakage of these periodontal pathogens. So they enter the bloodstream, and through the bloodstream, there is all possibility that they reach the fetoplacental unit. Now, once they reach the fetoplacental unit, they are known to colonize within the intrauterine atmosphere. Strangely, this is also seen in very clinically healthy gestations when the mother also shows some amount of oral microorganisms in their uterus. Now, how much is the role of these species specifically in the production of adverse pregnancy outcome, the pathogenesis? That we do not have still conclusive evidence. But what does the scientific literature say? In 1993, Offenbecker in his landmark study showed that when he injected pregnant hamsters with the lipopolysaccharide of Performa gingivalis, it led to potent embryolethal defects. And also, Swati et al. Showed in their study that in patients who are having hypertension, pregnant patients, periodontal pathogens were present in high proportion in subgingival plaque as well as in the placenta. And in another interesting study by Romero, wherein they saw in an amniotic fluid sludge in the intrauterine atmosphere environment, and when they further analyzed it, they saw that it was a microbial biofilm which was identified inside this sludge. A biofilm is not just planktonic microorganism, but it is microorganisms present in an extracellular matrix. So this was also scientifically proven. So we have very clear evidence to say that periodontal pathogens do travel from the periodontium via the blood and reach the uterus. Commonly associated pathogens are Fusobacterium nucleatum, Campylobacter rectus, Prochyromonas gingivalis, Trichonema denticola, and the Burgdella species. Now coming to the second stage, that is metastatic injury. So due to the presence of these pathogens or their byproducts, there is an inflammatory response. Now this inflammatory response may lead to some injurious or deleterious effects within the fetus and the placenta. So Offenbecker has showed that there are placental malformations, intrauterine growth restriction, some type of genetic attenuation of the genes also. So because of all these things, there is impaired growth or organ development of the fetus and may lead to adverse pregnancy outcomes. What does the scientific literature say? So RP in his interesting study showed that when the maternal mice which were infected with Campylobacter rectus, They have significantly decreased fetal weight and length because of the TLR4 mediated intrauterine growth restriction. So this was proven in animal studies. In human study also, when there was a term stillbirth and a biopsy of that fetus was undertaken, it was very clearly seen that gram-negative bacilli were observed in the amnion and subchorion, and they were positive for oral Fusobacterium nucleatum. So injury can occur, but we do not have still very clinically plausible studies proving in that direction. Coming now to metastatic inflammation, so there is increased pro-inflammatory cytokines from the liver release like prostaglandin E2, which is known to cause cervical whitening and uterine contraction leading to preterm birth, or C-reactive protein, which can cause intrauterine inflammation and thereby lead to preterm birth. There are some studies which have also shown that there is no association between inflammatory cytokines and preterm birth, but we don't have any conclusive evidence in this angle. Studies have shown by Stadiman in 2013 that there is an association between GCF inflammatory mediators as well as adverse pregnancy outcomes. Immunologically, the mother has actually downplays the immune response in order to protect the fetus. Thereby, in the bargain, there may be some altered immune response which will be affecting the fetus. There has been seen that in low birth weight deliveries were highly associated with higher maternal serum antibody level against P. gingivalis at mid-trimester. Similarly, live preterm birth was associated with decreased levels of IgG antibody to periodontal pathogens. So, contradicting reports are also seen in the scientific literature. So, in this regard, we do not have much consensus whether metastatic inflammation or altered immune response may be responsible for adverse pregnancy outcomes. This, in brief, is how the three pathways are influencing the adverse pregnancy outcomes. Now, what is positive? We do not have any evidence, but association, do we have evidence? Yes, plenty of studies prove in the direction that there is increased risk ratio, like in Bogus study, there is a 2.3 risk ratio. Tella Pragada study, there is a relative risk of 3.38, and also preeclampsia of AOR of 7 was noted. Similarly, we also have contradictory results which say that there is no relevant differences between periodontitis affected and non-affected individuals for preterm birth, like the studies of Moore, Agueda, and also Horton. So there is contradictory reports saying that there is association, there is no association. Now, what is the influence of nutrition? Nutrition definitely has an individual role to play on periodontitis as well as on pregnancy. But in adverse pregnancy outcomes also, nutritional deficiencies like vegetables, carbohydrates, omega-3 fatty acids, vitamin A, vitamin B12, vitamin C, vitamin D, vitamin E, zinc, probiotics, all their deficiency have shown to have some kind of effect on adverse pregnancy outcomes, and supplementation of the pregnant mother with these vitamins has proven to be successful in reducing these outcomes. What happens when we do periodontal therapy? Can we reverse the adverse outcomes? Again, contradictory results. Jeffcoat in 2011 said that we can reduce the number of preterm birth rate with periodontal treatment. Taranum and Feiselden in 2007 said that preterm birth rates can be reduced from 75% to 53%, which is quite a huge amount. But we also have plenty of contradicting reports by Polizos, Hooker, Schoenborn, Mikulovic, saying that there is no significant effect of periodontal treatment in any of the adverse pregnancy outcomes evaluated. So a systematic review where they analyze this very clearly states that treatment of periodontal disease with SRT cannot be considered as an efficient way of reducing the incidence of preterm birth. There we have it. So we cannot change the track of that. But a periodontitis affected pregnant individual will be benefited by undergoing non-surgical periodontal therapy and to keep the oral health good. So what do we conclude from this? There is strong evidence that periodontal pathogens can translocate, but how do they contribute? We still do not have clear evidence in that area. This may be exacerbated by certain post-immune response profiles. Non-surgical periodontal therapy during the second trimester of gestation is safe, but it doesn't affect the pregnancy outcomes. That's a point to be remembered. Specific intervention at a specific time point during gestation is not able to alter the fate of pregnancy. Interventions during the pre-conception period may also have a very significant role to play. So with this, I conclude my take on periodontitis and adverse pregnancy outcomes with clinical evidence. At this juncture, I want to thank Dr. Sangeeta Dheer and Dr. Sumida Bansal for giving me this opportunity to speak. Thank you.
Well, the presentation feedback will be shared with Dr. Pauline, certainly, and it has been a lovely hearing her once again. Over to the next speaker, and I would like to invite Dr. Sumida Bansal to kindly introduce Dr. Anupam Dekar, the last speaker of the day.
Yes, sure, ma'am. Dr. Anupam Dekar is working as a reader, Department of Periodontics and Oral Implantology in Regional Dental College, Guwahati. He completed his MDS in Periodontology from Regional Dental College, Guwahati. He was former lecturer at Buddha Institute of Dental Sciences and Hospital, Patna. He has presented papers at national conferences of the Indian Society of Periodontology and has been guest speaker at various conferences and continuing dental education programs. He is a visiting consultant in NemCare Specialty Hospital, Guwahati, and he is a committee member of Diabetes India Oral Health Group. Over to you, Dr. Anupam.
Thank you so much, madam, for the kind introduction. And it's been a great honor for me to be presenting amidst this galaxy of eminent speakers. And I thank Diabetes India Oral Health for the opportunity. And may I share my slide now?
Yeah, please.
Okay. The topic I'll be presenting today is orosystemic nexus, newer horizons. The speakers before me has spoken about diabetes and risk factors with cardiovascular diseases, then pregnancy. So periodontitis we have seen as a major oral infection may affect the host susceptibility to systemic diseases in three main ways. Number one, by shared risk factors. Number two, the periodontium acting as a reservoir of inflammatory mediators.
Anupam,
and number three,
Anupam, kindly just put on the large screen. Just magnify your presentations.
I think it's magnified.
No.
Yeah.
It's on the sorter right now.
Okay.
Put it on the full screen, please.
Full screen.
At the down, bottom right.
I'm not able to see this.
So it's okay. Just carry on. Carry on.
Just please press F5.
F5. Okay. F5. Yeah.
No, it's still
it's not working. No?
It's okay.
You can see three logo, the TV logo. If you click, it will go bottom right.
Bottom toolbar.
Toolbar. Yeah, I've seen the toolbar, but remote control apps, then more.
It's okay.
No. Okay, ma'am.
Anupam, just continue. No, it's okay. Just continue, please.
Okay. I think the events is controlling the screen now.
No.
Event,
you have shared it, na, Anupam?
Yes, ma'am. Yeah.
So you will be having the control, na?
Okay. So in three ways, the periodontium acting as a reservoir of inflammatory mediators and subgingival biofilms acting as reservoirs of gram-negative bacteria.
Is your presentation getting stuck, Anupam, by any chance?
I'll try once again, ma'am.
Or you can just quickly...
Yeah. Can you see this next slide now? Beyond the well-researched systemic conditions.
No, Dr. Anupam, you have to share the full screen. I mean, go back and then share the entire screen, not the window. Okay. Else you have to select each slide one by one, then we can. Now it is slide 3.
Is it coming, sir?
No. You can select slide one by one then from the slide sorter, left panel.
Okay, sir. Yeah. Okay, sir. Yes, I've shared. I've clicked on the shared screen. Yes. One is coming. It's coming as Zoom now only. Yeah. Yes. So, okay. Thank you so much. Yeah. Okay, I'll continue. Yes. Is it fine, ma'am?
Absolutely. Please continue.
Okay. So beyond the well-researched systemic conditions of diabetes, cardiovascular diseases, and preterm low birth weight complications, there has been a plethora of recent clinical evidences linking oral infection to a host of other autoimmune, dysfunctional, degenerative, and infectious conditions. So first, rheumatoid arthritis. There is a growing interest in the associations between oral health and autoimmune and inflammatory diseases. A number of epidemiologic studies have described associations between rheumatoid arthritis and periodontal disease. Periodontal disease is a prevalent and severe condition that can be present at all stages of rheumatoid arthritis, including the early stages, and the inflammatory microenvironment plays a significant role in the development of rheumatoid arthritis and worsens the systemic inflammation and immune response. So the mechanism has much to do with the most pathogenic microorganism of periodontology, that is Porphyromonas gingivalis. It influences the development of multiple chronic inflammatory conditions, and through the cross-reactive antibodies, and there is increased level of systemic inflammation like arterial thrombosis, and in rheumatoid arthritis, gut microbiome dysbiosis, metabolic disorders, etc., as well as overall microbiome dysbiosis. Here, in case of rheumatoid arthritis, there is a production of PEPD, that is the peptidyl dehydrogenase enzyme, which is responsible for the production of peptidyl citrulline from peptidyl arginine, and which leads to anti-citrulinated proteins. And the gut microbiome also affects the P. gingivalis in this respect. Then this is localized, and inflammatory responses can result in citrullinization, which breaks down the immunologic tolerance and causes the destruction of the cartilage and the bone, and aggregative bacteria actinomycetum commitans that also contributes a lot to this effect. So recent studies have highlighted the complex interactions between the oral microbiome and the host defense and immunological mechanisms. So a multidisciplinary approach is crucial for evaluating this condition. It is imperative to recognize the impact of periodontal disease on the development and progression of rheumatoid arthritis to provide timely and effective treatment. So here again, this slide, it just summarizes the effect of periodontitis and arthritis. They have shared risk factors like smoking, environment, and gut microbiome, and including genetic predisposition. So microbial dysbiosis resulting from periodontitis, it leads to the formation of, again, P. gingivalis, PAD, and generation of citrulinated proteins and production of ACPA. So leading to hypercitrullinization in PM and activation of citrulline enzymes. There is formation of rheumatoid factor autoantibodies, citrulline and antigen presenting cell. In evaluating the correlation between these two conditions with special attention to the microbiome, there has been no statistical significant differences between bacterial loads and serum values. On the contrary, a positive correlation was found between the presence of Porphyromonas gingivalis in periodontal pockets on one side and RF and anti-citrulinated protein antibody on the other. Therefore, the presence of Porphyromonas gingivalis in periodontal pockets is associated with rheumatoid arthritis inflammatory indices. Now, next is chronic kidney disease. The chronic kidney disease, it arises from abnormalities in the structure and or function of the kidneys present for more than 3 months and leading to compromised renal function. Main causes are diabetes and hypertension, and implicated in 2/3 of all cases. The remaining cases are attributed to immunological inherited conditions of unknown etiology. So this study, it shows the influence of periodontal and diabetic status in patients with CKD. Here we can see that in patients, the green line shows CKD only, and where the survival rate is, they have analyzed for 120 months and going up till 180. And in this condition, in this combination, you see CKD plus diabetes, CKD plus periodontitis, and CKD plus periodontitis plus diabetes. So in the last one, where there is chronic kidney disease, periodontitis, and diabetes, the survival rate is the lowest, as shown by the black line over here. And the green line, that is the survival rate among these, is the highest in only CKD patients. The clinical evidence behind the association between periodontitis and CKD derives from epidemiology and observational studies and intervention and clinical trials, as summarized in recent systematic reviews. And this evidence is usually presented in renal replacement therapy, dialysis or transplant, or non-renal replacement therapy populations. Now, there's an important article demystifying the connection between periodontal disease and chronic kidney disease, an umbrella review. And this assesses the quality of the current systematic reviews on the relationship between CKD and oral health, with an emphasis on periodontal disease, and to generate clinically relevant guidelines. It was conducted and reported in alignment with the Joanna Briggs Institute and PRISMA 2020 guidelines. This is a recent article. And this review collated the existing evidence regarding relationship between CKD and periodontitis, and which demonstrates that there is a bidirectional relationship between these two conditions. However, there is a difference in that in the strength of the mutual risk factor, periodontitis, the risk for CKD with periodontitis is much stronger than the reverse. That means patients with CKD may have periodontitis, but that is much less than there is a more chance of periodontitis patients developing into CKD. So moderate evidence for positive associations between periodontitis and CKD results exists. Evidence for the opposite direction is extremely weak based on significant heterogeneity between the studies. Further, there is weak evidence to demonstrate that non-surgical periodontal therapy improves kidney function and reduces systemic inflammatory burden by lowering systemic pro-inflammatory mediators. So since the evidence is weak, here the inference is that prevention of periodontal disease is of utmost importance. Now, this slide also summarizes this bidirectional relationship. On the left-hand side, we see the red arrows, which shows poor oral health related with unhealthy kidneys, and poor oral health as shown by increased plaque index, calculus index, probing depth and attachment loss. On the other hand, on the right side, we have these blue arrows, which shows the healthy conditions, where regular dental care results in less caries, less DMFT index, less periodontitis, leading to improved levels of the inflammatory factors like interleukin-6, albumin, and C-reactive protein. Plus, patients who are already on who are going for regular dialysis, they will have more healthier teeth as compared to patients who are not on regular dialysis, and which also improves the glomerulation filtration rate. However, more long-term studies are needed to confirm its benefits on CKD outcomes, so healthcare professionals should work together to provide timely care. Next, Alzheimer's disease. Alzheimer's disease characterized by accumulation of amyloid plaque deposits in the brain, general increase of inflammation in the brain modulated in large part by the microglial cells, and the fragmentation of tau proteins into microfibrillar tangles. These are some of the invasive biomarkers which can be got by CSF, then synaptic dysfunction, neuronal damage. This can be seen in Alzheimer's disease. Now, it is important to understand the possible upstream events in this. The most important thing to focus on here is the translocation of microbes, and which contributes to increase in amyloid beta plugs, and which results in more microglial activation and tau fragmentation and tangles, leading to clinical signs of the Alzheimer's disease like loss of memory, cognition, motor function, brain atrophy. And here, again, P. gingivalis is the main contributing factor. The gingipains and lipopolysaccharides from the P. gingivalis, they cross the blood-brain barrier and causes increase in the amyloid beta plaque formation. Bacteria from the oral cavity, but also from other sources like GIT, can translocate to the brain, including Borrelia burgdorferi associated with Lyme's disease, Helicobacter pylori, and periodontogenic bacteria, which includes Porphyrium gingivalis, T. denticola, AA, Tenerilia forsythia, Prevotella intermediate, Fusobacterium nucleatum. So using markers such as amyloid beta 42/40 ratios and phosphorylated tau protein in CSF as surrogate markers of Alzheimer's disease in the brain, higher levels of P. gingivalis DNA was found in the CSF, and in saliva they correlate with Alzheimer's disease. The relative ease with which these products of P. gingivalis may invade the brain may be facilitated by the potential of this bacteria to directly invade endothelial cells and secrete gingipains that can break down the tight junctions of the blood-brain barrier. In addition, the cells can survive in the epithelium and circulating cells of cellular immunity, which can then invade the brain as a Trojan horse through the lymphatic system. Translocation of these bacteria from the mouth to the brain can lead to local destructive inflammatory reactions as part of the pathogenesis of Alzheimer's disease and other systemic diseases. So targeted therapies like systemic administration of gingipain inhibitors may prevent Alzheimer's disease, and a personalized medicine and personalized dentistry approach that combines the targeted approaches to bacteria to reduce the amyloid, reduce inflammatory response, and lifestyle modification, assessment and modification of other risk factors. Now, cystic fibrosis, it is a genetic disorder inherited in an autosomal recessive manner, impairs normal clearance of mucus from the lungs, which facilitates colonization and infection of the lungs by bacteria, notably as aureus. Hallmark feature is accumulation of thick mucus in different organs. Adults with cystic fibrosis had poor oral hygiene practices, but interestingly, lower levels of clinical gingivitis and periodontitis. So this study by Coffey and Leary F., they investigated the prevalence of periodontal disease and oral hygiene status in adults with cystic fibrosis. There was a tendency, albeit non-significant, towards reduced periodontitis in patients with cystic fibrosis. The probable cause might be because they regularly took antibiotics, particularly azithromycin. So these tables from the study, it shows that in the blue bar, it shows the cystic fibrosis patients, and the orange line, it shows the controls, the non-cystic fibrosis participants. Here, in all the cases, we see that the percentage of gingivitis in each age group was higher in case of non-cystic fibrosis patients. Similarly, in case of mild periodontitis also, the periodontitis was much more in the controls than in the cystic fibrosis subjects. COVID-19, meta-analysis of epidemiologic studies indicated that periodontitis subjects are more likely to experience a more severe course of COVID-19, specifically, periodontitis was associated with a 4-fold increase in odds of hospitalization, 6-fold increase of the requiring assisted ventilation, and more than 7-fold increase chance of death due to COVID-19 complications. This emphasizes the relevance of the mouth systemic connection as a target to mitigate the current COVID-19 emergency. Then this table summarizes the representation of evidence regarding a possible correlation between periodontitis, periimplantitis, and COVID-19. Here, in case of periodontitis, there was higher pocket depth and bleeding on probing in patients with periodontitis and COVID-19, and it seems to be associated with higher risks of COVID-19. Periodontitis patients seem to be associated with a higher risk and complications of ICU admission, assisted ventilation, and death. In case of periimplantitis, however, there is limited evidence according to this study. So, in conclusion, we can say the studies of clinical oral health parameters, gingival microenvironment, autoantibodies, and biomarkers, and disease activity measures are providing a better understanding of the potential mechanisms responsible for a host of systemic conditions and periodontal disease associations. The cumulative results and ongoing studies have the promise to identify novel mechanisms and intervention strategies to improve the periodontal health and other systemic conditions. So thank you all, and a special acknowledgement to Diabetes India Oral Health Group for giving me the opportunity to present my talk. Thank you.
Thank you, Dr. Anupam, for a lovely presentation. Now we'll move on to the last leg of the evening today, and we invite Dr. Kanteshwari ma'am. Can we have a biosketch, please? Okay, it's a pleasure to introduce the very senior most periodontist of our country, Dr. Kanteshwari ma'am. She is Dean and Head of the Department of Periodontology, Sri Aurobindo College of Dentistry, Indore. Madam has been an alumnus of KLE Dental College, Belgaum, and is actively engaged in academic and clinical training for the past 26 years. She is presently affiliated to Sri Aurobindo College of Dentistry, Indore as a Dean. She is specialized in periodontology. Her areas of interest include clinical research and advanced treatment approaches, among others. She has authored numerous scientific publications in peer-reviewed journals and has been a guest speaker, resource person at national and international forums. She has shouldered administrative responsibilities in various capacities. She has received appreciations and accolades from academic bodies for her contribution to dental field, such as IDA President's Appreciation Award for consecutive 3 years and Education Leadership Award, to name a few. She is a music lover and an avid reader and practices yoga and spirituality. Over to you, Kanteshri ma'am, for the discussion round as we wrap up. Kanteshri, yes, ma'am. Yes, ma'am. Please.
So I would quickly wrap up because we are already running out of time.
Yeah, ma'am.
So we at the outset, I thank the DIOH office bearers and the organizers for giving me this opportunity. And yeah, let me begin. Dr. Anurag Satpathy began fantastically with his presentation.
And could you please put on your camera, please?
I'm trying to.
Okay. Otherwise, please come. Yeah, great. Good to see you.
Okay. Yeah. Okay. All right. So Dr. Anurag has a question. Is asked in the chat box, I see, that are there any studies on type 1 diabetes and gestational diabetes and latent onset diabetes and its effect on diabetes? I'll read out the question. Sir, we have a lot of studies on type 2 diabetes mellitus and its effect on periodontitis and management of periodontitis and its effect on type 2 diabetes mellitus. But were there any studies on type 1 diabetes, a gestational diabetes and latent onset diabetes and its effect on diabetes? Don't you think it is a need of the hour? I think they are asking whether there are any studies on type 1 diabetes related to periodontitis, I guess.
Yes, ma'am, I've answered Dr. Selvakumar's question there. That there are some studies on T1D, although we have a plethora of studies on type 2 diabetes, but T1D, we have some studies and almost negligible studies on gestational diabetes. What happens is whenever we are conducting a study, we try to exclude the mothers with diabetes in order to study. So we should not do that rather, and we should include them in order to see whether whether the therapy has any effect on the gestational diabetes. I think Dr. Purvi also can share her insights on those because I have not seen many studies on pregnancy and diabetes to be included in the periodontal studies. Type 1, yes, I have seen. There are several studies, but there are less.
Ma'am, if you can just repeat the question, I think my volume was a bit low.
So, ma'am, the question goes as, we have a lot of studies on type 2 diabetes mellitus and its effect on periodontitis and management of periodontitis and its effect on type 2 diabetes mellitus. But are there any studies on type 1 DM, a gestational DM and latent onset DM and its effect on DM? That's the question.
Yes, definitely. There are studies linking gestational diabetes and periodontitis also. And, I showed you graphically that picture also, that if you have metabolic problems during pregnancy plus, oral health issues or conditions like periodontitis, then it's really the perfect storm. You don't want that because while metabolic disorders are a harbinger of not only frank type 2 diabetes, but also cardiovascular disease, just having periodontitis further aggravates the inflammation and the bacteremic load as well, and can offset any of these at any time. There are enough studies to link the three, maybe not as many as type 2 and the rest, but there is a strong link seen there as well. And so is the case with type 1 diabetes and periodontitis.
I hope that answers the question of Dr. Selva. Dr. Rutu, there is a question for you that has been asked, and it goes as, what are the oral complications or adverse effects of the latest drugs administered for diabetics, if there are any? Is the question clear, Dr. Rutu?
Sorry, can you please ask it again, as my volume was also low?
Oh, it's okay. The question reads as, what are the oral implications or adverse effects of the latest drugs administered for diabetics, if at all there are any complications?
Exactly, I would say there are no such kind of drugs which cause any oral complications directly. We have not come across such things that any of the newer drugs, especially SGLT2 and GLP-1 receptor agonist, or even we have now imiglimine and lobeglitazone. There are multiple newer drugs. Even we have tirzepatide, which is not available in India, though, which is GLP-1 GIP receptor agonist. Yes, those drugs have higher tendency of maybe gastritis or related complications, which may cause some problem in oral problems in few of the patients. Otherwise, I don't know, because SGLT2 inhibitor mainly has acute infection of mycotic infection, but they are genital mycotic infection. But I have not come across any oral complications related to any oral hypoglycemic agents or even insulin and newer insulins as well. Dr. Hetty ma'am is also here. I would ask her as well if she has come across anything like that.
Purvi ma'am, would you like to answer?
Sorry, any of the drugs related with that?
Yeah, drugs related oral complications, newer drugs. I have not come across any.
No, nothing reported as such. Well, DPP-4 inhibitors and skin lesions or skin rashes have been reported, and we've been seeing sporadic cases in the last few years, because I think overall people have become more pharmacovigilant. So earlier, what used to get dismissed as not drug related, now people are looking for associations. But as far as as far as any specific oral manifestations, we haven't heard. Although oral lichen planus is also quite, it's a condition that has been seen in diabetes patients. So it's not completely unheard of, but definitely, we do see sporadic cases of oral lichen planus as well.
Thank you, Dr. Purvi. Dr. Kanteshwari ma'am, quickly you will summarize so that we can wrap up.
Yeah. Next. Yeah, from the presentation by Dr. Rahul Goklani on diabetes and cardiovascular disease, what I interested in the interesting fact noted was that not to forget the pre-diabetic stage is alarming, as we are always focused on diabetic stage. It is he stated that pre-diabetic stage is also alarming, as the CVD risks or the atherosclerotic risks begin at this stage. Is what one catch point I noted. Rest all was explained very beautifully by sir. And then from the presentation of Dr. Jayanti Dioh on relation between periodontitis and cardiovascular risk, Madam has explained very beautifully with epidemiological studies and evidences that how the likelihood of severe form of CVDs increases in the patients with periodontitis. And the studies that asked, another interesting point that she mentioned was that some studies have asked the participants to maintain strict oral hygiene, and they showed a reduced risk of CVD amongst the individuals, which underlines the point that all the CVD patients should be screened for the presence of periodontitis and should be given strict oral hygiene. And Dr. Purvi Chawla gave a wonderful discussion on diabetes and pregnancy, and Madam explained on gestational diabetes and its effect on not only on the pregnant woman and also on the newborn, and the health risk and the hypothesis, various insulin hypothesis. Ma'am took us through all the other further to the health risks of the newborn. That was very enlightening. And then the presentation by Dr. George Pauline on periodontitis and adverse pregnancy outcomes. Madam explained the 3 different pathways, focal infection pathways by which the periodontitis can affect the adverse pregnancy outcomes. And yeah, she also very honestly submitted that there are controversies. There are supportive evidences also, and there are contradictory evidences also, which do not totally agree that periodontitis can be that independent risk factor to adverse pregnancy outcomes. There are always confounding factors which contribute. So, but it still can't be ignored. Periodontitis is still considered a contributory factor to adverse pregnancy outcome in the presence of other confounding factors. And the last presentation by Dr. Anupam Deka, it was very wonderfully synchronized presentation where he also explained how periodontitis can be risk factor to other conditions which were included in this topic, other than diabetes, CVDs, and pregnancy. He's mentioned how rheumatoid arthritis, chronic kidney disease, Alzheimer's, COVID-19, how they all were related to periodontitis. So overall, it was very enlightening session. I learned many more things through this, and all the speakers in the given span of time concluded with both supportive as well as contradictory evidences and what we learned today and where we stand in this. So overall, this session gives us a hope that there's still a lot more to research in this area.
Thank you, ma'am, for shouldering this big boulder finally. And now I would love to introduce the last and final closing remarks by Dr. Sumedha Bansal. Can we have a bio sketch, please?
For me, it was most tensing session because I had to note down everybody's. I felt like I'm attending a class and like a student, I'm taking notes.
So that is why the responsibility was specifically shouldered to you.
Absolutely.
Neerav, can we have Dr. Sumedha's bio sketch, please? So here comes the lady who has been like a pillar and post support for I don't know for how many years, a dear friend as well. So let me introduce Professor Dr. Sumedha Bansal. She is ex-professor, Department of Periodontics and a senior consultant at Accord Hospital, Faridabad. She also maintains a private practice. She did her graduation from Postgraduate Institute of Dental Sciences, Rohtak in 2001, and 2007 she completed her MDS. She has worked as professor in the Department of Periodontics, Sudha Rastogi Dental College, Faridabad, where I was also a part of the faculty. She has more than 15 years of experience as clinician, academician, researcher, guide to graduate and postgraduate student. She has authored chapters in textbooks and has numerous national and international publications in journals of repute. Currently, she is working with Accord Hospital, as already mentioned. She runs a private practice, as already mentioned, and has a keen interest in periodontal medicine. Over to you, Sumedha, to close the show.
Thank you so much, ma'am, for the kind introduction. Well, that brings us to the end of this enlightening webinar. A big thanks to our chief guest, Dr. Viveka Kumar, our chairpersons, Dr. Dhruvi Asnani and Dr. Sangeeta Muglikar, for sparing their valuable time. I sincerely appreciate our honorable speakers, Professor Dr. Anurag, Dr. Purvi Chawla, Professor Dr. Pauline, Dr. Rutul, Professor Dr. Jayanti, Dr. Anupam Deka, for their interesting and explanatory lectures on the concerned topic, and of course, Dr. Kanteshwari ma'am for her lucid discussion and the way she wrapped up the whole topic. Thank you so much, all the speakers and our patient audiences too. Last but not the least, many thanks to DI Head Office, DIOH Organizing Committee and RX Events who have been instrumental in organizing this event. So we leave for now with a promise to return with some more informative programs like this. Thank you. Thank you so much, everybody.
So if anyone else is sitting mute or not appearing, can we just have you all on one frame? If they are there, Dr. Manoj, Kanteshwari man is logged in with 2. Okay, so signing off for this evening. And as Sumedha rightly mentioned, we'll reconnect again. There's a lot of agendas lined up for DIOH, and with this beautiful team that we are currently into 2024, with both the Generation Next and young Turks like Anurag in specific. So there's a lot to go. And Anupam, you were excellent and just fabulous.
Thank you.
So with this all, and thanks, Nirav. Nirav, are you there? Nirav, are you there?
Yes, ma'am.
Thank you so much for the backend team. I think if you guys were not there, we will be just falling apart. So thank you so much, RX team, for this wonderful evening and airing this through. And we sign off for now. So good night, and we connect again. Thank you so much, all of you, for being there.
Thank you.
Bye.
Thank you so much. Bye. Bye.